Hello, and welcome to the Wellness Masterclass Genetics Series. Today's featured speaker is certified genetic counselor Mandy Kass, and she will be discussing BRCA and U, a genetic counselor's guide to the BRCA genes and hereditary breast cancer. Let's all welcome Mandy.
Hi, everyone. Thank you for joining us this evening. As Voncel mentioned, my name is Mandy Kass. I'm a certified genetic counselor, and I've been with Ironwood for a little over 4 years now. And today we're going to be talking about hereditary breast cancer with a special focus on the BRCA genes. So the goals for the talk tonight are, of course, as mentioned, to really talk quite a bit about the BRCA genes. We're going to also spend some time looking at kind of the historical origins of these genes and how we've gotten to this place today where we can offer this testing so readily to the general public. We're also, of course, going to talk about when should you and your family consider genetic testing for some type of hereditary breast cancer risk, and what we can do about a hereditary breast cancer risk if we do identify that in someone. We'll kind of jump right in with the historical origins of BRCA. About 50 years ago in the 70s, we didn't really know a lot about what caused cancer. And this whole idea that cancer could be hereditary was generally not well accepted. But despite that, it was pretty undeniable that we would see these families where there was this clustering effect of, early onset breast cancer or ovarian cancer, which is a more rare cancer type. Sometimes we'd even see male breast cancer happening in these families. And it kind of led to this question as to what was happening that was causing these cancers to take place within the family. So in 1974, Dr. Mary Claire King actually began her research to really try to determine if breast cancer could be inherited genetically and if there was a specific gene mutation that could be the culprit for that. So over the next 17 years, so from 1974 to 1990 approximately, Dr. Mary Claire King really spent a great deal of time working with human geneticists from around the world and studying different families to try to figure out what the cause was for these cancer clusters within these families. And ultimately, she identified a specific location within our 17th chromosome. And basically she identified a gene that she named BRCA1 that was the culprit for a lot of these cancer clusters that we were seeing within these families. Now, of course, today we know that there's not just BRCA1, there's BRCA2 as well. They're essentially two different genes that are kind of working on the same pathway within our body to ultimately protect us from breast and ovarian cancer, along with several other cancer types, which we'll talk a little bit about. Now, of course, at this point in time, this testing was really only being offered on a research basis. So it wasn't something that you could walk into your doctor's office and say, I would like the BRCA testing. But that kind of changed in the mid-1990s when Myriad Genetics, a genetic testing laboratory based out of Utah, started offering this BRCA analysis testing to the general public. So this was a pretty huge thing within the field of medicine and genetics to actually be able to offer this testing to patients and then use the information to better guide care. But unfortunately, that didn't come without some ethical and some legal consequences. And that's because at the same time that Myriad Genetics released that BRCA analysis testing, they also patented the BRCA1 and the BRCA2 genes. So essentially, Myriad was not only the first company to be able to offer this testing, but they made themselves the only company that could offer the testing. So as I'm sure some of you could imagine, this led to a lot of debates that went on for many, many years about whether or not we should be allowed to patent naturally occurring material like our human DNA. And ultimately what ended up happening was in 2013, the Supreme Court stepped in and they invalidated those patents or essentially took them away. So it seemed like overnight there were other labs that were finally able to offer this same testing. And in turn, that actually led to a lot of people being able to access the testing that at one point couldn't access it because of the high cost. So that was a big turning point for genetic testing. Now, 2013 was not only a big year for the field of genetics because of the invalidation of those patents, but also because 2013 was the year that Angelina Jolie kind of ignited this national or more or less global dialogue when she announced that she had a preventative mastectomy and a preventative oophorectomy, or the removal of both ovaries. And this was because she was found to carry a BRCA1 gene mutation. After she made this announcement, the amount of women and men also in the United States getting the BRCA testing actually increased by 40%. So it was a pretty significant advancement in terms of the awareness and the interest in our genetic material. That kind of leads me into the next part of this talk, which is really, how do we figure out if someone has a hereditary risk for breast cancer, and what can we do about that? So we'll take a look at some numbers here. Now, we know that about 1 in 8 women will get breast cancer in her lifetime. It's unfortunately a very common cancer type. But we also know that about 70 to 80% of those breast cancers are sporadic, meaning that they're likely not hereditary, and they're probably caused from an accumulation of genetic damage that we acquire throughout our lifetime. And this genetic damage can happen because of different environmental exposures, different lifestyle factors, even just normal aging. So essentially non-inherited traits. Now, you'll also see that lighter pink section of this chart here indicating that about 15 to 20% of breast cancers are thought to be familial. Now, what we mean by this is that sometimes we see this clustering of breast cancer occurring within a family. And of course, usually the first thought is, well, if there's this clustering of the same cancer type in the same family, it's got to be genetic. But in this case, we think that this clustering is actually happening because, of course, families share genetic factors, but oftentimes they also share an environment and they share a lifestyle. So, for example, we could see a family that maybe grew up in an area where there was a large amount of radiation exposure. And maybe that's why we're seeing that clustering pattern of breast cancer within the family. Or maybe we see a family that all shared a similar lifestyle. Maybe they weren't very active or lived a more sedentary lifestyle. Maybe they didn't have the healthiest diet. And maybe because of that, we saw more people in the family with obesity, which we know is a risk factor for breast cancer. So again, these familial breast cancers, we think are likely the cause of our shared environment and our shared lifestyle. Now, the dark pink part of the pie here, you can see, is indicating that about 10% of breast cancer is hereditary. So this means that there is a single identifiable genetic mutation that is moving through the generations of that family that's causing people to be at a higher risk to develop breast cancer. And of course, BRCA1 and BRCA2 are generally the most common genes that are associated with hereditary breast cancer, but there's certainly a whole group of others. And we're going to spend a little bit of time today talking about some of those other genes as well. But first, let's take a closer look at those BRCA genes specifically. So this chart really illustrates the cancer types that are associated with a BRCA1 or a BRCA2 gene mutation. And this chart is comparing the cancer risks with the average person's risk, or the general population risk. So essentially, people that do not have a BRCA gene mutation or any other hereditary cancer risk. So breast cancer, of course, is kind of the #1 cancer on this list. We know that the average woman's risk for that cancer type is about 12%. But with a BRCA1 or a BRCA2 mutation, we see that risk approaches close to 80%. So it's a very significant increase. Now, of course, there's some other cancers you'll see listed on here. Ovarian cancer is certainly another cancer type that is associated with these BRCA genes. But it's important to also keep in mind that men are not exempt from these BRCA gene mutations. We oftentimes first think of the women in the family because of that high breast and ovarian cancer risk, but men are also more susceptible to male breast cancer if they have a BRCA1 or especially a BRCA2 mutation. There's also a higher risk for prostate cancer, pancreatic cancer, and possibly melanoma as well for individuals with a BRCA gene mutation. So as promised, we're going to take a look at some of the other genes that are linked to hereditary breast cancer, because we now know that BRCA1 and 2 are not the only players in the game. So ATM is certainly one of those genes that we have linked to hereditary breast cancer. We think that the risk for hereditary breast cancer in someone with an ATM mutation is somewhere between 17 to 52%. So you'll notice that's a pretty big range. You know, those are two very different numbers, 17 and 52. So oftentimes the way that we can try to better determine what end of the spectrum someone is more likely to fall on is by taking a closer look at that family history and really trying to map out how many females are there in the family, how many have been affected with breast cancer, how many have not, and then sometimes that allows us to kind of gauge what end that person might be on. Now, ATM is not only a gene that's linked to breast cancer risk, but also pancreatic and prostate cancer as well. So again, two cancer types that can have implications for men as well. BRAC2 is another female breast cancer risk gene. However, it's a gene that's also linked to a higher rate of male breast cancer, colon cancer, and prostate cancer. So again, men in the family, it's important for them to know. And I keep mentioning that because so many times we're only thinking about the women in the family, but it's really important to keep in mind that men could have some risks as well that they should be aware of. LB2 is another hereditary breast cancer gene. This gene is also linked to male breast cancer, pancreatic cancer, and possibly ovarian cancer as well. Just a few more with you. CDH1 is another hereditary breast cancer gene. Now, typically, the main type of breast cancer that we see for women with a CDH1 mutation is lobular breast cancer, but we typically also see a higher risk for gastric or stomach cancer as well. And with this particular gene, we actually think that the risk for stomach cancer is so high that we typically recommend a preventative gastrectomy or removal of the stomach. Just because it is a difficult cancer type to screen for. So if we know someone has a very high risk to develop that, we want to do everything we can to better keep that person safe and be preventative. 10, another hereditary breast cancer gene. This gene is also linked to a higher risk for thyroid cancer, colon cancer, uterine cancer, also kidney cancer should be on there. The interesting thing about P10 is that sometimes we'll find that individuals with a P10 gene mutation also happen to have a larger than usual head size. So as genetics providers, if we're ever suspicious of the P10 gene for a patient, a question we might ask is, do you ever have trouble finding hats that fit you? Because the patient might say, you know, yep, my whole life I've never been able to wear hats. They're always a little too small. And then that's kind of a tip off for us that might be something that we need to be taking a closer look at. And then TP53. This is another hereditary breast cancer gene. The risk for female breast cancer with this gene is exceedingly high. You know, you'll see 90% there. In the past, we even used to quote that risk as high as 100%. Now this gene, we in genetics kind of have called it the guardian of the genome, and that's because it does a lot for us to help protect us from different cancer types. So typically in families with a TP53 gene mutation, we're going to see a lot of different cancers generally happening at a very young age. We might even see some childhood onset cancers happening in these families. So it's always really important that we try to identify who these families are so we can make sure that they're set up with appropriate screening. So now that we've kind of talked about the BRCA genes and some of these other genes that are linked to hereditary breast cancer, I can imagine that some of you might be wondering, how do we determine if someone might carry one of those genetic mutations or a hereditary risk for these cancers? And there are some warning signs or some red flags that we can look for to help us better determine if someone might have a higher risk for carrying one of these hereditary predispositions. So the first thing is cancers that are occurring at a younger age than usual. So certainly if I see a woman developing breast cancer in her 20s, 30s, 40s, that's going to look suspicious for some kind of hereditary cancer risk. So we would definitely want to consider some genetic testing at that point. certain patterns of cancer in a family. So, we talked a lot about the BRCA genes and their strong association with breast and ovarian cancer. So if I see those two cancer types specifically within a family, I'm definitely going to want to make sure that we offer some genetic testing to see if there could be some kind of hereditary risk. More than one type of cancer in a single person. So in this case, I'm not necessarily referring to someone that's had a metastatic cancer or cancer that is spread from one organ to another. Instead, I'm referring to individuals that have developed multiple primary or separate cancers. So maybe a woman that's had breast cancer and then several years later develops uterine cancer. We just don't expect to see people getting more than one cancer type in their lifetime. So when we do, we want to make sure we're taking a closer look at maybe what might be going on genetically. Cancers occurring in both of a pair of organs. So in this case, if I see a woman with bilateral breast cancer or breast cancer happening in both breasts, that's going to look a little bit more unusual and maybe it's linked to some kind of hereditary risk. So we would definitely want to consider some genetic testing at that point. And then individuals in each generation affected by cancer. So this is where that family history comes in. It's really important to be able to use that family history as a tool to better determine if we are seeing cancers moving through each generation of a family. And if we do, that might be a bit of a red flag for some kind of hereditary risk. Now we can imagine at this point that, let's say we've got a patient in front of us, they had some of those red flags, so we went ahead with genetic testing and it came back positive for a genetic mutation that put them at a higher risk for breast cancer. What do we do with that information? We don't do this test just to scare people. We do have a plan that we can follow to better manage those risks. So we'll go through some of those options together. The first thing is regular monthly self-breast exams. And this goes for all women. Even if you don't have a hereditary risk for breast cancer or a family history of breast cancer, all women should be doing those regular monthly self-breast exams. Clinical breast exams performed by a physician or a provider that is knowledgeable on breast health. For someone that has a hereditary breast cancer risk, we generally recommend that these clinical breast exams take place every 6 to 12 months. And basically, for anyone that's not familiar, the clinical breast exam just involves the physician or the provider feeling the breast tissue and just making sure that they don't feel any unusual lumps, bumps, any changes that might prompt further imaging. High-risk breast cancer screening you'll see listed on here. Basically what this entails is an annual mammogram and an annual breast MRI. And what we like to try to do is space these imaging techniques out every 6 months. So essentially, if I had a mammogram today, 6 months from now, I would do the breast MRI. 6 months after that, we would do the mammogram again, and we would kind of follow in that pattern. And the goal there is that if breast cancer were to develop, we would hope that we catch it at an early treatable stage because we're just not letting as much time lapse between the imaging. Chemoprevention. So there are essentially medications out there that women can take that will help reduce their risk for breast cancer. So we always recommend that women that are interested in learning more about chemoprevention, that they talk with a medical oncologist who can really review the benefits and the risks that go along with that kind of medication. And then of course, risk reducing surgery. Several slides back, we talked about Angelina Jolie and her decision to undergo a preventative bilateral mastectomy to reduce her risk of breast cancer. So that's certainly an option that's on the table for a lot of these women that are found to have some kind of hereditary breast cancer risk. So again, these are just kind of all of the options that we have for women that are found to have these high risks. There's really no one right or wrong answer. It's just a matter of what feels the most comfortable for that individual patient. Now, generally the next question for patients, once we've kind of gone through how a positive genetic test result might change their care, is how is this going to impact my family, especially if it's someone that has kids. So we do know that most hereditary breast cancer risks follow an autosomal dominant pattern of inheritance. So what this means is that basically, if we look at this illustration here, we can imagine that Dad has a BRCA1 mutation, okay? And mom, on the other hand, does not. So, you know, we all have 2 copies of our BRCA1 and BRCA2 genes, one from mom, one from dad. So in this case, mom only has working copies to pass on to any future children. Dad, on the other hand, has 1 working copy and 1 non-working copy. So what that means is that when they go on to have children, there's going to be a 50% chance that a child could inherit that BRCA1 mutation and have the higher risk for certain cancers, but there's equally a 50% chance that that child might inherit the working copy, meaning no increased risk for those BRCA1 associated cancers. Now, of course, this also goes for full siblings. So let's imagine that dad has, 5 sisters and 2 brothers. They all also have a 50% chance to have that same BRCA1 mutation. And that's because we would assume that that's something that was inherited from his father and probably goes back many, many generations within the family. But essentially, if someone carries that hereditary cancer risk, there's generally going to be a 50% chance for the next generation to also inherit it. So now that we've kind of spent some time talking about the BRCA genes, other genes associated with hereditary breast cancer, kind of what we do with that information if someone is found to have one of those risk factors, I want to kind of open up the floor for any questions or anything that I can better clarify for people.
Thank you, Mandy, for that valuable information presentation. We actually do have questions from our digital audience. The first question: how long does it take to get genetic test results back?
So it usually takes about 2 to 3 weeks. Now, if we've got someone that needs to make a surgical decision quickly, we can order a STAT test, meaning that we generally get those results back in generally about a week or so, but on average about 2 to 3 weeks.
And our next question is, can I schedule an appointment with you even if I have not been diagnosed with cancer?
Yes. So the genetics department is happy to see any Ironwood patients, or if you're an employee, we'd be happy to meet with you as well and talk about the testing options and your family history and kind of make a plan from there.
And our final question is, I had genetic testing done in 2010 and it came back negative for BRCA mutations. Do I need to redo the testing?
So yes, I would recommend updated testing. In 2010 or the early 2000s, again, the BRCA genes were really all that we were looking at. And from this presentation, you've seen that there's a lot of other genes that have more recently been discovered that could have some implications. So I generally always recommend that patients that did have testing, 5+ years ago, and if it did only include BRCA1 and 2, that we consider some updated testing to start including some of those more recently identified genes.
Thank you so much, Mandy, for this presentation. And thank you to our digital audience for joining us for the Wellness Masterclass Genetics Series. We hope you enjoyed this session. There will be a replay of this Lunch and Learn on the Ironwood YouTube and social media channels. For more information regarding our Supportive Care Services Department resources, classes, and events, email us at wellness@ironwoodcrc.com. Thank you and good night.